Hi, I'm Dr. Scott Laborowit. I want to share how I use the Ngenuity 3D visualization system in a small pupil. I'm a consultant for Alcon. This is highlighting how the Ngenuity can engineer the light source, and software can allow you to maintain the depth of focus during a case, but in a small pupil it's exceptionally challenging. So the unique software in this technology allows you to see the white sclera, the iris, but also in a smaller aperture it can be more challenging to get light in and visualization of structures. So as you watch this case, it's to highlight how you can maintain that view with this technology. In a traditional microscope, you just have the light source and you can adjust if it's oblique or direct light and the intensity. Where here you can still do those things with the microscope, but again, the software in the Ngenuity is optimizing your image while maintaining depth of focus in a 3D platform. It doesn't hurt that you're working off of a 55-inch monitor, that you sit 4 to 6 feet away and you can recline or sit in any position. Sometimes in tricky situations where you're trying to get your phaco tip or INA in hard to reach areas, you actually need to adjust your shoulders and elbows, and not being stuck in the oculars allows you to do this. So this case has a pupil of 5.1 millimeters. A femtosecond laser created a 5.0 millimeter capsulotomy. The anterior chamber was filled with viscoat, and I went under the capsule to lift up the capsulotomy that was created. I then visco dissect 270 degrees to the equator, and the air bubble from femtosecond then pneumo dissects the posterior component of the lens adhesions. The phaco tip is just used to remove the central 4.8 millimeter lens cuts, so the 20 pieces are removed. It's important to also notice that there's a digital cockpit for the surgeon, so I'm not relying on the circulating nurse or the technician. So you can see here the pre-phaco setting in the digital cockpit, and then I switched over to sculpt, and I can visualize that while I'm operating. I'll also often use the CDE and adjust my technique when I see that I've reached a certain level, trying to keep any trauma to the cornea as low as possible. With femtosecond technology, I adjust my technique where I bowl out the lens. I know I can continue to sculpt deeper as long as there's cuts in the lens. I still have a 500 micron cushion. I also have a chop pattern that extends to 5.3 millimeters, so I'll at the end be able to still crack this lens into 4 perfectly sized quadrants. So you can see the extended depth of focus allows me to see the anterior capsule as well as the posterior aspects of the lens without zooming in or focusing during the case. At this point, with the CDE slightly higher, I chose to then crack the lens into 4 quadrants utilizing the pre-existing laser chop that was created. The bowl is 4.8 millimeters, and because of this size and the laser cut quadrants, as I pull quadrants in, I can stay deep in the capsular bag because the geometry works, allowing for these pieces to be brought in to the bowled out area, staying away from the cornea. Extreme depth of focus provided by the Ngenuity really gives you confidence in using your second instrument and placing it to pull pieces central. With this visualization, you can see all the tissue structures. You don't have to refocus while you're working, and it gives you confidence to use the second instrument knowing exactly where you are. The pupil is now at 4 millimeters, and again, this video is to highlight how even in a small pupil, the Ngenuity is able to engineer an image that allows you good depth of focus and able to visualize structures with a good red reflex as well. In this case, I utilized a femtosecond laser to leverage the technology to allow me to remove a central bulge out area that is deep within 500 microns of the posterior capsule, and then the chop pattern creates 4 equal quadrants that can then be pulled into that bulge out area and removed within the nuclear bulge out area, which is within the bag far away from the cornea. It becomes a pupil independent technique because I'm bowling out within the pupil even if it's 5 millimeters or less, and then pulling quadrants in. Having a good visualization allows me to then pull quadrants through the cracked area into the central bulge area. It's allowed me to avoid using pupil expansion rings in the last 5 years because of this technique. At this point, INA is used under the iris in the smaller pupil. Since the femtosecond created a 5 millimeter round opening, I know exactly where to go with the INA tip to sweep the anterior cortex looking for cortical material. You can see how nicely you're able to visualize the iris along with the posterior capsule and the cortical material without adjusting focus and maintaining an excellent red reflex despite the smaller size pupil. A 90-degree tip is used here to get the subincisional cortical material. You could also use a bimanual technique as well. At this point, to further inspect for remaining cortical material, I use a single Kuglen hook to retract the iris. This avoids any microsphincter tears that pupillary expansion devices may create and therefore avoids a surgical pupil. You can see here that there is some cortical material remaining, which is now visualized and removed. The eye is then filled with viscoelastic, and aura is integrated into the Ngenuity system. As you can see here, the monitor is split in half and the aura is on the right side, so I do not have to switch monitors to visualize for this segment. I then zoomed in for purposes of avoiding patient identification, but you can see because of the intraoperative aberrometry, I did adjust my intraocular lens power by a half a diopter. Returning to the full screen, I then place the intraocular lens in the capsular bag. At this point, the pupil is approximately 3.5 millimeters, and again, there's still a good red reflex and a great ability to visualize the intraocular lens and the capsular bag. You can see the rings of the multifocal intraocular lens. I then reintroduce the Kugel hook to again retract the iris to confirm the intraocular lens is within the capsular bag. This is just to demonstrate that as you zoom in, it remains great focus, so you can go under higher magnification to verify, in this case, that the intraocular lens is within the bag and under the anterior capsule. So the Ngenuity is able to keep the colorization stable. You can have a good red reflex, but you can also visualize the details under higher magnification if necessary. Since this is a drop-free cataract surgery, I'm injecting anterior chamber moxifloxacin, followed by 0.15 subtenon's Kenalog, which is placed with the patient looking down 8 millimeters supranasal to the limbus. Again, notice I did not have to adjust my focus. I just at this point wanted to highlight some advantages with the Ngenuity system. This is utilization of the operating microscope. I have to keep my body at a certain position within inches of the oculars over the body. It limits my ability to use my elbows and wrists as I try to maneuver to certain areas in tougher cases or different size bodies or stretchers. Here with the Ngenuity system, I'm able to sit back and position myself at anywhere from the head. You can see I'm now further away from any microscope, and I can recline back and more comfortable. This also highlights that you can use thumbnail images to adjust your colorization, so the temperature could become more red or more blue. To optimize your image, you may decide to change this each case or just once. I also can choose the light source from XENON to HALOGEN. I personally prefer the XENON light. As demonstrated earlier, you can zoom in tight for visualization if you're concerned during a certain step of your procedure. We've talked a lot about having this depth of focus and good red reflex during surgery. You can see the posterior capsule bubbles. while also seeing the cuts in the lens. They're created by the femtosecond and the capsulotomy. Here's the bowled out lens in a larger pupil, just showing the extended depth of focus. With the good visualization, it allows me to have more aggressive use of my second instrument. In most of the case, my phaco tip tends to stay central in the visual axis, while my second instrument will reach behind, given the stable chamber and good visualization, pulling pieces into my phaco tip. It's become an excellent teaching tool. This is 9 third-year residents watching femtosecond surgery, and you can see they see the same image as I see as long as they're wearing the glasses. The aura is fully integrated in the system as well, and it helps for toric alignment with the overlay. Thanks for watching the video, and I hope you learned some pearls in small pupil surgery using the Ngenuity.